So, welcome back to the latest episode of Taking Charge of My Cancer podcast. And I have as a guest today Dr. Michele Ruiz. She earned her PhD in clinical health psychology from East Carolina University and completed a predoctoral internship here at UF Health Science Center, specializing in health psychology. Currently, she is a postdoctoral psychology fellow at the University of Florida, specializing in solid organ transplant and psycho-oncology services. Her clinical work centers on coping and adjustment among medical complex patients. This primarily includes delivering psychosocial interventions in outpatient and inpatient settings, while working with an interdisciplinary care team to meet the physiological needs of patients. She balanced postdoctoral fellowship work at the University of Florida Health Science Center with community outreach aimed at extending mental health care to underserved population. In addition to research that informs clinical practice and advanced cultural responsive care in medical settings. So, Michele, thank you so much for being with me today.
Of course. Thank you for having me.
Absolutely. So, as a PhD in clinic health psychology, how do you define the mind-body connection in cancer care?
I think that's a really important question and one that I want to give some clarity around because I have so many patients who come in who are afraid that if their mental health isn't right, that they're going to progress their cancer, negatively impact their treatment. And that's not at all how I view the mind-body connection. It's more so this recognition that our physical health very much affects our mental health,
Mhm.
right? And then vice versa, not biologically, physiologically, but more so of it's really hard to keep up with treatment when you're not feeling well. It's
Mhm.
really hard to get the support that you need when you're feeling tired and fatigued. And so the whole field of psycho-oncology came out of that recognition that cancer causes distress and cancer impacts patients' quality of life,
Mhm.
and very much leads to anxiety, depression, etc. And so it really ranges kind of some of the different mental health concerns that we see in our patients, but it's just recognizing that this is a condition, a disease that causes distress. I think the statistics out there are about a third of cancer patients have meet criteria for a mental health disorder.
Yes, and I'm not sure if you're aware of that. I know that you kind of be in the postdoctoral part of it, not so much involved with the clinic itself, at least in our side here in outpatient cancer. But we actually have occupational therapists who work with us,
Mhm.
who is a lot of his path is like mental health. And
Yeah.
in the beginning, when we started to implementing that, I didn't think really was going to work that great because it's like, we see patients for pre-op about, 2, 3 weeks after a breast cancer diagnosis. So patients are really overwhelmed,
Hmm.
kind of like they're in that waiting time that is the
Yeah.
harder part of it. And so I felt like in the beginning that was going to be really very like putting something else on their feet, on their plate that was just gonna overwhelm them even more.
Hmm.
And so in the beginning, I was like, let's maybe just do this on the post-op setting to see where they already had the surgery and they know what's gonna happen more. And then it's like, Tony, who is the occupational therapist who works with it, is like, no, you know what? I think that actually I can help actually during that time of the most anxiety and, you know,
Hmm.
scare in the beginning. And I'm like, well, let's give it a try. And my
Yeah.
God, the feedback that we have from patients has been
It's
unreal.
it's so funny you mentioned that because a lot of our patients who get referred to our psychology service have already seen your occupational therapist and
Mhm.
they rave about them that even just like the deep breathing helped them so much in managing some of their anxiety. And so I think, oh yeah, a lot of the patients are really satisfied with their care. And I know that there's occupational therapists who specialize in mental health because one of my childhood best friends is actually a mental health OT.
So that's great. So it's so good. And again, he's not a psychologist by any means, but a lot of the tools that at least we can start this patient with
Mhm.
until I make it to you guys, will you
Course.
have more like the knowledge and try to continue manage them throughout the whole survivorship is just great. So what happens psychologically when someone at first hears the word you have cancer?
Mm. Well, I don't think there's any one reaction to those words, nor is there a right way to feel. There's a whole spectrum of emotions that come up, right? Like there's the fear, the anxiety, all the uncertainty about the future. I think of a lot of our patients also have a lot of anticipatory grief, especially for kind of later stages, more terminal cancers, and have a lot of loss. Some of our patients even feel a lot of guilt and stigma, especially cancers that can be tied back to certain behaviors, like thinking about
Mhm.
tobacco use and lung cancer. And so it's a really complex disease, and I think one's emotional reaction really varies just depending on the stage of cancer, the type of cancer, whether or not the treatments that they're being presented are known to be effective. But really, we see it quite almost like kind of those stages of grief,
Mhm.
but different stages of emotions. And my patients really describe it more so like a roller coaster versus this like linear process of stages of emotions.
So you think that if this, you mentioned something in the beginning of our conversation, some patients think that if they already have, I don't want to say an unstable mental health, but they already
Hmm.
struggle
Yeah.
in keeping up with those kind of like stressors,
Hmm.
how can we prepare them better for what's coming down the line with them as they get diagnosed with cancer, right? So
Hmm.
like, I see these patients in pre-op, right? So I see this patient too, like I mentioned before, 2, 3 weeks after diagnosis. And if I know they have a history of like anxiety or depression or anything on those lines,
Hmm.
I want to be able to give them some tools to help
Yes.
them during that time. And again, I'm not the expert,
Hmm.
but we do so much education and they really appreciate us to just slow down and explaining a lot of things that sometimes, they're overwhelmed. And even though the doctors here are amazing and spending a lot of time with them, sometimes they come to us and like, this is the first time they hear this. And I know it's not because I know how everybody else in the team has been already talked to them about that, but they only capture a little bit of it. And it's
Hmm.
so much information that I want to be able to talk to them a little bit different. So
Hmm.
that's somebody who does not have that kind of like a past medical history or background.
Hmm. That's a great question, and I think a lot of physicians I have heard be really afraid to share news with patients who have a history of mental health conditions or disorders. And my response to that is to not be afraid of recognizing that people are strong and information only promotes autonomy in their decision making. Of course, being sensitive and, making sure that you're communicating this in a good space. If someone has a lot of distress in the moment, maybe helping them with some deep breathing and helping them relax before presenting more information. Because then exactly what you described, right? When we're overwhelmed, we're not retaining information. But I think just giving people all the information at hand, of course, not catastrophizing, but
Mhm.
also not don't protect patients by withholding information. That's actually unhelpful to anxiety because it leaves them with so many more questions and so much uncertainty. And so almost being matter of fact with here's what we know about your diagnosis, here's like your treatment options, and just being patient while you answer all their questions.
Okay, that's very good tips. How can patients begin coping with the loss of control, anxiety, and depression that often follows a diagnosis?
Well, coping alone has such a huge body of literature studying this concept. But I think that the most like common or at least the most well-known definition of coping is by Lazarus and Folkman. And they really emphasize that coping is a process, right? It's all the cognitive and the behavioral efforts that we go about managing stress. It
Mhm.
unfolds over time. It's this process. And it's not, coping isn't defined by whether something is effective or not effective. As humans, we learn how to cope based on our past experiences. But sometimes the situation at hand is not a good fit for that coping mechanism, right? And so for a lot of my patients who have a new diagnosis, they're facing a lot of uncertainty, and they have a lot like that sense of loss of control. Um, that makes me think anxiety, right? That's kind of the definition of anxiety. And some of the ways they've gone about coping with anxiety in the past is problem solving, of wanting to have a solution, control all the possible situations. But it's very much like a Chinese finger trap, right? Like the more you pull, the tighter it gets, and it's not helpful in this situation. And so I really try to emphasize with my patients more emotion focused coping, right? That so sure, the problem focused coping is helpful for like making sure you have the information to make an informed decision. But outside of that context, it's more so focusing on what you feel and managing some of those emotions. And so relaxation strategies, right? Diaphragmatic breathing. Some folks really like square breathing. Mindfulness meditation, being more so in the present, being able to let go of some of that worry. There's so many resources on that, both on apps, YouTube. You can just Google those, and there's plenty for people to experiment and see what fits with them. I also really like self-compassion when it comes during this period. Kristen Neff has a lot of resources online on self-compassion. And these work often because obviously they're not changing the situation, right? Like cancer is still present.
Yeah.
But when you're in fight or flight and super anxious, these help with lowering some of that arousal, turning on the parasympathetic system, right? And kind of allowing us to have some mental clarity to
Mhm.
then decide the next steps, right? Whether that's problem solve, maybe lean on social support. And so I really like those relaxation strategies as kind of like that first line of interventions.
You mentioned four
Square
breathing,
breathing?
square
Yeah,
breathing,
like four, like you hold in for a count of four,
four,
pause
seven,
for a count of
eight.
four. Hmm.
Okay, so four, four, four. Is another one that is like 4, 7, 8.
Yeah, there's there's a lot of versions of diaphragmatic breathing. I think for patients who are trying to comb through all this information, to keep it simple, basically focus breathing into your belly. That's where you get the most oxygen in. You expand your diaphragm versus shallow breaths in your chest. Um, and to have either a pause or a longer exhale than inhale. And so if you just want to focus on that, that works too. I think it's so confusing, all the different resources on breathing out there.
Yeah, yeah, but I think you're right. The more I hear, I've been kind of like, of course, since I started the podcast, listening to other podcasts, and it's amazing. Like everybody talks about the breath work and
Mhm.
calming the parasympathetic system and vagus nerve and all that.
Mhm.
And I used to not really like I always been good about like diaphragmatic breathing just because of my exercise background and everything, but never really work into that breath work and has been really good. I really enjoy
Mhm.
doing that when I feel like okay, this is getting a little bit overwhelming or a stressful
Mhm.
situation. That has been really a good tool.
Yeah. And again, it's different from, I think sometimes when we're stressed out and the people in your life tell you, like, oh, just take a deep breath. And it
Uh-huh.
feels really minimizing and almost makes you really mad that someone's telling you to take a breath. I feel like this is a little bit different because it's a very intentional practice. You want to practice it for at least 5 to 10 minutes to really get the benefits from it. And again, it's more so about like lowering some of that arousal so that you can move forward and kind of choose your next steps. I really try to emphasize with my patients, this is not fixing the problem. It's just
Mhm.
allowing us to be in a place to fix the problem.
Very good. What are the most common emotional struggle patients face during active treatment?
I think the primary one I see is anxiety. Cancer treatment itself, is associated with so much physical discomfort, so many side effects, potential complications, especially when people are getting into surgery. And not only is the treatment itself cause a lot of anxiety, but then of course the uncertainty of one's prognosis and what it could mean, right? Especially in the beginning when people don't have a lot of answers. so many of my patients, while I love my chart and like patient charts for like the apps, they get their diagnosis first through a my chart message. And then
Terrible.
they don't get a call from the doctor until like if they get it Friday afternoon, they're sitting the whole entire weekend with that fear of what it means until Monday morning and they get to get a
Terrible.
call.
Yeah.
So I think anxiety is the most common response that we see, but there's also depression and loss. A lot of patients might feel hopeless, right? They might feel almost like this anticipatory grief of like, what if I die? What does that look like? How is it my family going to react to that? And so there can be a lot of changes in one's mood. And I think also too physically, right? Like all these treatments cause a lot of fatigue, a lot of pain, and that in and of itself is going to bring someone down,
Mhm.
limit how much enjoyable activities they can do, which is like the one thing that tends to make us feel better. Um, and I think for men especially, I see some of the depression with like loss of identity, especially if they've been providers for their family and
Mhm.
now they have much more disability or physical impairments and just really struggling with the adjustment. Um, and so these are all, I think, pretty common reactions. And that's why actually with a lot of my patients who have come in after cancer diagnosis, I don't typically diagnose like generalized anxiety disorder or
Mhm.
major depressive disorder. I usually diagnose adjustment because
Mhm.
they're just having a very normal response to this
Mhm.
diagnosis.
Of course. Okay. So how do this anxiety, depression, or trauma response affect physical recovery and rehabilitation? Because we know mind and body work all together,
Hmm.
right? So when we
Yes.
have a challenge in one, we kind of coping with the other, but how
Hmm.
they kind of like correlated.
Yeah, and it kind of goes back to what I said earlier. I want to reassure people that if your mental health is struggling during this time, that's normal. And there is not much evidence to suggest that that alone is
Mhm.
going to affect cancer survival, right? And I just want to take some of the pressure off my patients because I'm like, I can't imagine the pressure you're under that if you don't feel mentally well, you're not going to recover. Really, we think about mental health disorders affecting cancer treatment and kind of our recovery through like different pathways. One of them is just like socioeconomically of people who have a history of mental health disorders are at greater risk of like unemployment or lower educational attainment. And that's usually associated with less financial resources. So they might not access like preventative healthcare screenings. Um, and
Point.
that might delay their diagnosis. So that's one pathway.
Mhm.
Or I think for a lot of our patients who maybe have depression, anxiety, PTSD, and trauma, they might also have low self-efficacy. And sometimes patients who don't feel very confident in their ability to take care of their health just don't have as much motivation to go seek preventative health care.
Okay.
And then, of course, behaviorally, some mental health disorders can be comorbid or associated with like more substance use or poor nutrition. And that could affect one's physical health. But I think a lot of what we see is also like the ways we go about coping, right? Some folks' response can be avoidant, right? Like we're very afraid and we don't feel like we can handle bad news. And so we might not seek out healthcare
Okay.
or even the opposite. Some people overseek healthcare that if they feel any symptom, right, they're presenting to the ED with like, I think I'm having a heart attack. And so those are the more common mechanisms that I think mental health disorders affect, like that treatment seeking and physical recovery. And again, it's less so of this direct pathway between our mental health impacting your recovery or your treatment.
And one thing as well to add to that, again, one of the things that I always tell patients is how important exercise is and how
Mm-hmm.
important that is going to help them with their mental health.
Mm-hmm.
So if you go into anxiety, depression, even brain fog, all that, because we're really stimulating everything to help
Mm-hmm.
really, we have this long conversation with patients who harder for them to do when you're being sedentary and it's not part of your life to exercise, and they struggle with that to
Mm,
get into a regimen of exercise, and how is that so important to recover from these treatments. But as well, kind of like challenge a little bit the mentality of the ones who already get used to exercise, because
mhm,
you feel like you kind of, I really want to drop it right now because I don't feel like I have time for this, or I'm afraid to move the way I used to move or live.
mhm.
So we are super like on top of that, right? So of course I'm a
Yes.
physical therapist, so it's all about let's do movement and let's do exercise, because that is nothing wrong. I mean, that helps so much with anxiety, depression,
Mhm.
besides, just enhance all the treatments that they get through cancer and recovery time. So,
Yeah, I think that behavioral pathway is like where we all mostly intervene, right? Of like you mentioned, the fear, right, of exercising. Some people are afraid they're going to make it worse and they're afraid to exercise or even just afraid of the pain. And we know that depression, anxiety can actually increase our sensitivity to chronic pain and lead to a lot more catastrophizing. So there's that avoidance of physical activity, of going to the doctor because we're afraid, which is
mhm,
completely natural, right?
mhm,
Our brains are trying to protect us from going through any distress. And so behavioral is where a lot of psychology, I think UA and physical therapy and occupational therapy help patients kind of overcome some of those mental barriers.
mhm. What are two or three evidence-based strategies that patient can seek and how to access to them?
I love they said evidence-based, right? Because not all therapy is the same.
Yeah.
And, I definitely encourage patients to seek what feels like a good fit. But I'm a little bit biased as someone who mainly operates in cognitive behavioral therapy and some of the third wave interventions that I really emphasize evidence-based strategies versus more of like supportive talk therapy that while that's very helpful, ultimately some of the skills that we start to implement into our lives is where we start to see change and see improvement in some of these symptoms. So cognitive behavioral therapy has some of the largest evidence base for depression, anxiety, even PTSD and other traumas. Um, for cancer specifically, I really like acceptance and commitment therapy. So the difference between those being CBT targets like how we think and how that affects our behaviors and our feelings, right? Acceptance and commitment therapy is a little bit different in that it's aimed at improving one's psychological flexibility. It's not about getting rid of distress, getting rid of negative emotions. It's actually allowing them to be there because they're a very much valid part of our internal experience.
Mhm,
And so it's being able to accept some of the things in our life, one of them being cancer, right? Being able to kind of separate a little bit from those negative thoughts and just be present in the moment. And then one of the biggest parts about it is trying to live in line with our values and commit to living in line with those. And so, if patients out there who are listening to this and who are interested in seeking therapy, I would definitely be on the lookout for someone who's advertising that they use evidence-based strategies. And personally, I really recommend CBT, ACT, or even like behavioral activation to help learn skills along the way.
will you give the audience a little bit of an example? What is a CBT, like line words?
hmm Yeah, so cognitive behavioral therapy, some of it is the relaxation strategies I talked about earlier, right? About being able to just lower some of our arousal. A lot of it is cognitive work, in that, again, just based on past experiences, especially people who also have like depression or anxiety. And I'm saying depression, anxiety just because they're the most common mental health disorders, but generally, we tend to have more negative thought patterns and they're very automatic. And sometimes we don't really evaluate whether or not those negative thoughts are accurate. And so some of the cognitive work is just trying to create new thinking patterns and be a little bit more balanced in our thinking. We're no longer like catastrophizing or jumping to conclusions. And the behavioral part of cognitive behavioral therapy, a lot of it is getting re-engaged in our life, right? So a lot of folks who are struggling with depression, it becomes quite a vicious cycle of once the depression starts, right? Whether that's for biological reasons or there's stresses in our life, we lose our motivation and we start to disengage, we start to isolate, but that continues to feed the depression. And so people really get stuck in this cycle. And so the behavioral piece might look like just engaging in valuable activities. Sometimes with my patients, I'll send a list of pleasurable activities. And you could even Google pleasurable activities list, and like there's like hundreds on there of
Okay.
small, usually free activities to start doing just to build momentum and start
Okay.
to lift our mood up just a little bit so that the next one seems easier. And so I really emphasize do not wait for motivation because it will never come when you're feeling down, and
Yeah.
just focus on building momentum one thing at a time.
Okay. So how can patients manage that fear of recurrence without letting it dominate their daily life? This is something I come across a lot, right? So what patients usually feel like we kind of hold their hand through the diagnosed path, right? Who like we call them thousands of messages, you seeing this person and you're doing this and you're doing that. Then they go to treatment and we're still paying attention to how everything is going with treatment. The
Mhm.
treatment is done. And they're like, oh, you're good, you see me in a year, call me if you have any questions. And they go from being having, they feel like, everybody has been holding their hand to all of a sudden you just drop them. And they
Mhm.
and they're like anything they feel is like, oh my God, I'm feeling this way. It's just the cancer back, or it's normal for me to
Mhm.
have this because now I'm having cancer. So how can patients manage that?
I think, and this is going to go a little bit back to the one therapy model I was talking about of ACT. Part of it is acceptance of the fear of recurrence doesn't really ever go away for my patients. It'll always be on the back of their mind that they have that risk. And
Mhm.
every time they have an upcoming appointment, that's going to trigger fear.
Yeah.
Like, I have a scan, I hope it's good news, but like there's a possibility it's not. And I think that's a very valid fear.
Yeah.
And so I don't necessarily try to like reassure people that like, oh, it'll be okay. Because
Yeah.
we don't know that information. And so I really like this metaphor that's used in ACT called the passengers on the bus. It's a really common metaphor that ACT therapists use, but it's telling patients like imagine that your life is a bus and you're the bus driver, right? The journey is like your life's journey, and the bus represents your values and your goals, and you are the driver of that bus. You get to decide where it goes. And so in this metaphor, as you drive along the bus, you have to stop at the bus stop. That is your job, right? And you have to pick up the various passengers of life. This is the negative thoughts, this is the fear, the anxiety, the memories of potentially really traumatic treatments. And they're not pleasant, right? And they're demanding. They might shout at you, they might tell you you're going the wrong way. And in this metaphor, you can't kick these passengers off the bus. Like they will be there. But the
Mhm.
more you try to fight with them and get involved with them, right, the worse it is. Now it's a big ruckus, it's a fight back and forth. And so the acceptance piece is that instead of fighting with them, right, you can acknowledge, yes, they're there, they're annoying, they're scary, I don't like them. But ultimately, you are in the driver's seat, right? And you can continue to drive in the direction of your values, even with these rowdy passengers on the bus, right? And eventually they get off where they get off. And so that's how I try to talk about fear of recurrence is that it's a passenger on your bus.
I like
It's
that.
annoying, it's disruptive, but you can commit to continuing to drive your bus in the right direction, even with that passenger there.
I really like that. I think I'm going to start using that. I like that. That's going to stick with me. How does cancer reshape your identity, body, imagine, and intimacy?
Oh, I think it affects like every aspect of it, especially just depending on the cancer. There's just so many bodily changes that come with cancer. And some of it is like appearance, right? Like alterations in your appearance, hair loss. So as you know, like our service works most closely with Dr. Spiegel. And so most of our patients have breast cancer. And so they have hair loss. It really affects like their femininity. And then, of
Mhm,
course, surgery, they might have to go through a double mastectomy. They have swelling, scarring. And so, it affects your body image.
mhm,
There's also sensory changes. A lot of our patients have pain, they have numbness, and some of them have functional impairment, right? And so I've seen a variety of reactions, and it's a hard question just because it's like, it just really depends. Women with breast cancer, they might not feel so confident in their body anymore after it's been through so many changes. They really struggle with, society tells us what is feminine and like what's the ideal body for a woman. And it's like all of a sudden that's changed.
mhm.
Um, and even it comes up in their relationships, right? Of like feeling confident with your partner after going through those changes. For a lot of patients who have like head and neck cancers, who might like have visible scarring, they can feel really anxious going out in the world, right? Like it's a very vulnerable position to be in when you look different
Yeah.
and you can't really hide that. And so they might develop almost like a social anxiety and a fear of going out in public. Or even things like weight loss or weight gain, depending on the medications.
Mhm,
Things like all of a sudden needing like a colostomy bag, and like what that feels like.
mhm,
And so I've really seen kind of the broad range of how cancer shapes our identity, especially again working with breast cancer, gender identity, body image, and it's hard to be intimate when you're struggling with some of those feelings.
So how families or what communication or strategy help couples or
Mhm.
family navigate this season together? So you have, somebody who feels that way. Let's the example of the woman who got breast cancer by
Mhm.
laparoscopy. And then I know sometimes the significant other try to really be there for them, but some
Yeah.
like what else can they do to make them feel like they're there for them? I have seen so many patients that don't even tell their family that they're going through
Yeah.
this struggling, which is like I'm telling them, don't do that because you're gonna be even
Mhm.
more like stressful about, oh, somebody's gonna know and how they're gonna respond versus is so much support you can have when people knows. So, but what kind of communication strategies would you recommend?
Yeah, I agree with you that the more support you have in place, the better. And so it really requires a lot of open communication. Partners have responded a number of ways to my patients. Some partners completely awesome. They're there, they go to every appointment. Some partners not so much. They have their own anxieties and maybe don't know how to be there to support a person. And so one thing I really try to work with patients on is first recognizing the people in our life are not mind readers. They don't know what you need if you don't tell them.
Mhm,
I think a lot of us, especially when you have a partner or family who's known you all your life, you're like, they need to know, like they should know what I want. And it's like, actually, they don't, because you are very different people and you have very different needs. And
mhm.
so being open about needs, I find I statements are really helpful for that because it's expressing what we're feeling and what we need without blaming the other individual, making them feel defensive, right? And so I statements is a really common tool for communicating what we need.
Would you mind to give an example of an I statement?
Mm-hmm. So it's the structure of it is like I feel X when X, Y, Z, the emotion and the situation. So I feel anxious when you arrive home late because I'm worried about this happening to you.
Right.
And
Yes.
then being able to follow that up with the compromise of like, can you do this for me to help with anxiety? It requires openness to be able to go back and forth and compromise because there's a chance the person can't do that, right? And so being able to compromise, almost approaching it like negotiations, right? Of like, here's what I can do, what can you do? Another common communication skill is called Dear Man, and I feel like the acronym, it's an acronym and it's going to leave me, that it's used in dialectical behavioral therapy. It's describing the facts, kind of very similar to the I statement, and expressing what you feel, being able to assert what it is that you need. And I believe the R is being realistic about what that is. Oh no, reinforce, being able to then reward them for providing what it is you need. And the man part of Dear Man is being mindful, appearing confident, and being able to negotiate. And so these are acronyms that give patients some structure, right, on how to express the things they've been expressing. It takes practice. Some patients I always recommend like first journal it out to kind
Mhm.
of get a sense of exactly what it is you feel. You could
Mhm.
even try practicing with someone else to then
Mhm.
feel a little bit more comfortable with it before then using it in the relationship. So it's really helpful for just, and I think also because so many of the patients I work with are tired of feeling like patients. And
Mhm.
everyone in their life is like trying to dote on them and do everything for them. And they're like, no, that's not actually what I need.
Yeah. Yeah.
And so again, the mind reading, right? Well, it's like if you don't say that, how would they know? They're, people are trying to be helpful the way they know and sometimes just need direction.
Yeah. And you bring really a good point sometimes when I have patients who come back to see us as a new patient and they come with a relative or significant other. I always want them back with them here just because I feel number one, because it's so much information, so two brains can capture that
Mm-hmm.
information, that only one. But at the same time, it's a reassurance for that caregiver that it's okay for the patient to do things. You either have most of the time caregivers tend to enable the patients, right? Because it's like, no, 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 you cannot move because you're just gonna have
Yep.
surgery. You cannot do this because you just got diagnosed with cancer. So
Mm-hmm.
you wanna put them in a little bubble and then I'll just bring
Yeah.
it to
And
you
they
and
need to be getting out there. Mm-hmm.
exactly. So it's the opposite. And again, perhaps 30 years ago, 20 years ago, we used to treat patients with cancer like that. No anymore. Right now, it's like, no, no. I want them to work out. I want them to do if they can work, continuously work, if the treatments allow them, absolutely. It's so much better for them
Yeah.
because now they just continue their life versus when they stop everything. Every little thing that they feel, they're going to focus on versus if their mind
Mm-hmm.
is distracted doing what they do every day, either work or kids or whatever
Mm-hmm.
they go around, their mind is just going to be busy and they're not going to have time to think about, oh, now I feel this numbness on my finger now because this treatment, or so that works so much better. So yeah.
I think that's an excellent point of like what's helpful and versus unhelpful because I also like to tell my patients like yeah like bring a friend, a family member and like have them be the note taker, for example,
Yeah.
so that way you're just present in the visit, you're allowing yourself to feel what it is that you feel, and you have someone that's getting the facts for you to revisit
Yeah.
later and taking notes, asking questions, versus right the other way people like to help of like trying to protect them. And really, you're just reinforcing anxiety by
Hmm.
not allowing them to experience that for themselves and like slowly re-engage with their life. So I think that's a great example of like what you could say to a loved one of like, this is helpful, this isn't.
Okay. For someone who finished treatment but still feels emotionally unsettled, what message of hope would you offer?
I struggle with this one because it's like I don't know how much I have to offer to someone who's been through cancer, right? In the sense of like they're the expert of their lives and everything they're feeling is pretty valid. My message of hope is that as humans, we are resilient beings. We're
Mhm.
like rubber bands, we can get stretched, but we come back and we get through it. And even for patients who kind of will always have that fear of recurrence, who are always having that uncertainty, that doesn't mean you have to disengage from your life, right? A lot of my patients, I'm always so impressed by them because they find that silver lining, they find what's
Mhm.
meaningful to them, and they make changes that makes their life more worth living. I've had
Mhm.
a lot of my patients who, after cancer, they're like, I'm working a job I don't love, and that is such a waste of my time. I'm going back to school and I'm doing this because I now know that life is precious. And
Yeah.
so I think our resilience as humans is amazing. I know in the moment that's not much of a comfort, right? You kind of have to go through it to get through it, but I think that's my wise words for patients.
And that's very well said. I want to add a little bit to that, and I tell this to every patient. I have no meeting a patient for the most part who doesn't become healthier after a cancer diagnosis, which
Mm,
is great, but it's sad, right? Because we should be preventing, we should be being healthier to try to avoid a diagnosis like this or any other chronic conditions, right? But unfortunately, you have to go through that part of your life to realize, man, I shouldn't be putting that in my mouth, or I should be exercising more, or I should be really pay attention to everybody who say how sleep is so important, or
yeah.
like really doing the breath work or doing all these other things that now we're
Mhm.
learning to just manage what we're going through. That sometimes, again, when things happen, you're right, happen for a reason, and that's a way for you to discover other ways because you just see life in a different way.
And I think that patients are completely valid to be angry about that and to grieve that they no longer get to be carefree about some of these health behaviors. And I also want to be careful of, like, I think for a lot of patients, the messaging of like this happens for a reason really gets to them, of because then they're stuck looking for a why,
Mhm.
of like, why did this happen to me? And I sometimes like to just talk to patients about, like, there really isn't sometimes a sense to why things happen,
Mhm.
right? That bad things happen to good people, good things happen to bad people, and there isn't always a sense to it. But cancer and really any traumatic event really disrupts that sense of justice that we carry as humans, right? We believe the world is just, and all of a sudden here's this thing that like proves that wrong. And
Mhm.
so it is really disruptive. And I think patients have every right to feel angry about it, to grieve that, before you can come out on the other side and like reevaluate what's important to you.
Yeah, that's awesome. So I can continue talking with you forever. That has been an amazing conversation. So where can people reach out to you, or if they have questions or if they need to go see someone?
Well, I am currently in the UF Health Psychology Specialties Clinic. We're located in the North Tower of UF Health on Archer Road. So I'm trying to look up our phone number right now. So our phone number is 352-265-0294 if people are interested in like our clinic. For me personally, you can reach me at Michelle 24 Ruiz at ufl.edu. And I'm happy to kind of help guide people in the right direction and kind of help them get some of the answers that they need. I
Excellent.
unfortunately don't have my own practice necessarily that they can like just contact me to start working with me, but you can contact the clinic. And I'm happy to kind of help people along the way as well.
Great. And I'll put that on the show notes so people will know how to get a hold of you. So, Michelle, that has been wonderful. Thank you so much for being part of the show.
Of course, thank you for having me, like I said.
Okay, perfect. You have a great, wonderful rest of your evening.
Thank you.
Okay, bye.